Welcome everyone. In this video, we shall be talking about SGLT-2 inhibitors and discuss all the questions related to it. SGLT-2 inhibitors are our gliflozins. Right. So moving on to the first question. SGLT-2 inhibitors decrease blood glucose primarily by. Now remember that these SGLT-2 are present in our renal PCT. And they reabsorb. They are responsible for reabsorption of glucose along with sodium and water, right? So SGLT-2 inhibitors are going to inhibit these SGLT-2 receptors that will lead to decrease in glucose reabsorption and increase excretion of glucose in urine. Okay. So increase insulin secretion, that's a false statement because this is done by sulfonylureas. And GLP-1 analogs. Decreased hepatic glucose, this is also a false statement because this is done by metformin. Increase urinary glucose excretion, yes, they increase glycosuria. SGLT-2 inhibitors cause glycosuria. And increase insulin sensitivity, that is also a false statement. This is done by thiazolidinediones like pioglitazone. Right. Okay. Moving on to the next question. Now the effects of SGLT-2 inhibition by dapagliflozin include decreased plasma glucose independent of insulin. Yes, that's a true statement. SGLT-2 inhibitors decrease plasma glucose by increasing glycosuria. They have no effect on insulin. Rather there is mild increase. in glucagon. Okay. Increased ketone production. Yes, this mild increase in glucagon in a patient with already decreased insulin levels is responsible for lipolysis. Excess free fatty acids in the presence of increased glucagon and decreased insulin will lead to production of ketone bodies, will lead to ketogenesis, right? So this is also a true statement, and this acts as a risk factor for decay. And over here, since the glucose is lost in urine, we might get euglycemic decay. Okay. Natriuresis, as already discussed, because SGLT2 it does causes SGLT2 causes natriuresis because SGLT2 not only reabsorbs water but also reabsorbs sodium. As the name suggests, SGLT2, sodium glucose linked transporter. So sodium and glucose are linked. So with glucose, sodium is also lost along with water due to SGLT2 inhibition. So that's a true statement. Hypervolemia, that's a false statement because SGLT2 inhibitor increases urine output. This will cause dehydration. And decrease in blood pressure. This will cause hypovolemic situation. Okay. So A, B and C are correct. So option C is ठीक. Moving on to the next question. Which of the following has the highest SGLT2 selectivity? This is a factual question. Empagliflozin is our answer. Remember that empagliflozin has the highest sensitivity, followed by ertugliflozin, followed by dapagliflozin, followed by canagliflozin. Empagliflozin has the highest SGLT2 sensitivity. A factual question. Moving on to the next question. A diabetic patient is started on empagliflozin. Which change is most commonly expected? Which change is most expected in this patient? Okay. Increased insulin levels. No. As already discussed, SGLT2 inhibitors do not affect your insulin levels. Fasting hypoglycemia. Again, fasting hypoglycemia is related to your insulin levels, right? Again, there will be no effect on fasting hypoglycemia. Okay. Increased hepatic steatosis. That's a false statement because they decrease hepatic steatosis, because SGLT2 inhibitors decrease hepatic steatosis, right? That's why they might play some role. That's why in NAFLD associated with diabetes, they're used in NAFLD associated with diabetes. Decreased body weight and SBP, yes, that's a true statement. Decrease in body weight is due to glycosuria and decrease in SBP is due to natriuresis. Okay, so D should be a correct statement. Okay. Moving on to the next question. A 58-year-old diabetic with chronic heart failure and an ejection fraction of 30% and a CKD stage 3 needs glucose lowering. He is already on metformin and glimepiride. Which of the following is the best drug to add? Now remember that SGLT2 inhibitors have two unique features. They improve our cardiovascular CVS outcomes. They improve the cardiovascular outcome, and they also slow CKD progression. They also slow CKD progression. These two are very unique features of SGLT2 inhibitors. Over here, a diabetic patient has both chronic heart failure excuse me, chronic heart failure and CKD stage 3, right? So SGLT2 inhibitors should be the best answers. So C, empagliflozin should be an answer. Sitagliptin has no role in cardiovascular outcomes. Pioglitazone is rather contraindicated in congestive cardiac failure because pioglitazone causes sodium and water buildup, in our body, causing edema. Edema in congestive heart failure is very bad. And acarbose again has no role in cardiovascular disease and CKD. So our answer should be empagliflozin. Okay. Moving on to the next question. The most common adverse effect of SGLT2 inhibitors. My bad. It should be most common adverse effects of SGLT2 inhibitors. Okay. Pancreatitis, no. Pancreatitis is the side effect of GLP-1 analogs or DPP-4 inhibitors. Genital mycotic infection, yes. This is the most common side effect of SGLT2 inhibitors, and this is due to candida. Infection. Okay. Lactic acidosis, no. Lactic acidosis is the side effect of metformin. Okay. And severe hypoglycemia is seen in insulin and sulfonylureas. Okay. So over here, genital mycotic infections are the most common adverse effect of SGLT2 inhibitors. Moving on to the next question. A type 2 diabetic on dapagliflozin presents with vulvovaginal pruritus. What is the management? This vulvovaginal pruritus is due to candida infection. And this is due to use of dapagliflozin. Usually we know that whenever there is a side effect due to a drug, the first thing that we should do is stop the drug. But over here, this is an exception because over here the type 2 diabetic patient, we are using SGLT2 inhibitors. We are getting only a mild candidal infection. Then we won't stop the drug. We will continue it along with antifungals. But if the disease progresses, we will stop the drug, right? So answer, the choice over here should be antifungal therapy and continuing the drug. But if the disease progress, then we would stop SGLT2 inhibitors. Okay. We would stop SGLT2 inhibitors. Okay. Moving on to the next question. Now, SGLT2 inhibitors increases the risk of euglycemic decay. Yes, we have read that there is a mild increase in glucagon. There was already decrease in insulin in the patient, right? These two factors leads to lipolysis. And this lipolysis is responsible for ketogenesis, right? And this is responsible for decay. And over here we get euglycemic decay because of the glycosuria that is occurring, right? We get euglycemic decay because of the glycosuria, right? SGLT2 inhibitors are not allowing reabsorption of glucose in the renal PCT. That's why the glucose levels are normal, but we are getting acidosis and ketosis. Fournier's gangrene, yes, we do get this Fournier's gangrene. It is nothing but the necrotizing fasciitis of the perineum. Okay. Volume depletion, we have already read. There is natriuresis. There would be decreased reabsorption of sodium and water besides glucose. That's why, yes, we do get volume depletion. UTIs, yes, we do get UTI. This UTI is due to glycosuria. Increased glycosuria will, of course, increase the risk of UTI. So all the options are correct. Our answer should be D. Again, an INI type question. Okay. Moving on to the next question. A diabetic patient was on multiple drugs. For his glycemic control is presented with the following complaint as shown in the image below. Which of the following drugs is responsible for the given presentation? Now, this is our Fournier's gangrene. Right, which is nothing but a necrotizing fasciitis of our perineum. Right, and this is one of such unique side effects of SGLT2 inhibitors. So our answer should be A, SGLT2 inhibitor. Okay. Moving on to the next question. Now, contraindicated EGFR for initiation of SGLT2 inhibitors. Although we have read that SGLT2 inhibitors are used to slow CKD progression, but we cannot use in every CKD cases, right? Up to CKD stage 3 we can use SGLT2 inhibitors, right? Beyond that we cannot use. CKD stage 3 means up to 30 ml. Up to 30 ml. So our answer should be D. Below 30 we won't use it because it increases the risk of dehydration, and euglycemic decay. Okay. Moving on to the next question. Avoid SGLT2 inhibitors in recurrent UTI. Yes, it increases the risk of UTI, so we would avoid it. Dehydration, again SGLT2 inhibitors increases the risk of dehydration, so we will avoid it. In type 1 diabetes is already a risk factor for decay, so we would avoid SGLT2 inhibitors, which is another risk factor for decay, so we would avoid it in type 1 diabetes. Again, in pregnancy we would avoid it. We have already discussed in our decay video, right? Why pregnancy is one of the risk factors for euglycemic decay, because the fetus absorbs most of the glucose from the maternal blood. That's why we can get euglycemic decay. So all of them, in all of the conditions we should avoid SGLT2 inhibitors. D should be our answer. Okay. Moving on to the next question. A 54-year-old man with type 2 diabetes mellitus presented to the emergency department with abdominal pain, nausea, vomiting, rapid deep breathing. Started on ketogenic diet 2 weeks ago and has been taking empagliflozin for the past 4 months. Vitals में BP of 96/60, heart rate 118, respiratory rate of 32, SpO2 98, lab reports plasma glucose 138, pH of 7.18, bicarbonate of 12. What is the most appropriate next step in the management? Now from everything present over here, we can very well make sure that this is nothing but decay, right? Now over here we can also see this rapid deep breathing. This is our Kussmaul breathing. This is our Kussmaul breathing, right? As a compensation for the metabolic acidosis. Moreover, the respiratory rate is also high, right? Besides this, our glucose level is 138. So this is our euglycemic decay. Euglycemic decay, and this makes sense because the patient is on ketogenic diet and empagliflozin, which is a risk factor for euglycemic decay. Now, what is the most appropriate step? First option, stop SGLT2 inhibitors. This is one of such convincing answers. Yes, right. One important thing that we need to understand before this, that the management of euglycemic decay is first fluids, and then after 1 hour we would add insulin to it. Then after 1 hour we would add insulin to it, right? We won't provide insulin along with fluids because that can lead to vascular collapse. We have discussed this in our decay video, right? You might refer to it. So moving on to the next option, give IV insulin with IV dextrose and aggressive IV fluids. This seems to be a very correct answer, but this is an incorrect statement because we do not ever provide insulin along with IV fluids. It's always IV fluids, and after around an hour we would give insulin, right? Otherwise that can lead to a vascular collapse because insulin has the property of causing vasodilatation. Okay, and if insulin causes vasodilatation in an already dehydrated patient, that can be fatal. Next option, give IV bicarbonate. That's a false statement because the indication for IV bicarbonate and a decay is pH less than 6.9. Over here the pH is 7.18. Okay. And start an SGLT2 antagonist, that's a false statement. This would just worsen the condition. So over here option A should be our correct answer, although option B seems like a correct answer, but this shouldn't be our answer because we do not provide insulin and fluids at the same time in a decay management. Okay, so the answer should be A. Moving on to the next question. To prevent euglycemic decay, what should we do? Hold drug before surgery. This drug over here is SGLT2 inhibitors. Yes. Before surgery, we should hold the drug for 24 to 72 hours. That's a true statement, right? Otherwise, that can lead to a perioperative euglycemic decay, right? Because of increased stressful situation. Surgery is a stressful situation, right? There would be increased requirement for insulin. That's why that can precipitate decay. Avoid ketogenic diets. Yes, of course. Ensure hydration, of course, because that can lead because dehydration is one of such precipitating factor for decay. And increase insulin during stress or illness, of course, because in case of stress, whenever there would be a relative deficiency of insulin, because in stress you require increased amount of insulin, so that might trigger euglycemic decay. Okay. So all of the following are correct, so the answer should be D. With this we come to the end of our discussion on SGLT2 inhibitors. If you like this video, consider subscribing to my channel, and thank you for watching.